Good evening, everybody. We'll be discussing very important abstracts for HER2 positive breast cancer. So the first one is trastuzumab deruxtecan or TDXD versus TDM1 in patient with HER2 positive metastatic breast cancer, results of the randomized phase 3 study Destiny Breast 03. So progress has been made in HER2 positive metastatic breast cancer, yet there is huge unmet need. And the world has moved from trastuzumab to pertuzumab to TDM1, and now there was a good amount of data of effectiveness of TDXD from Destiny Breast 01 study. So just to differentiate between TDXD and TDM1, the mechanism of topoisomerase 1 inhibitor in TDXD, whereas it's an anti-microtubule mechanism in TDM1. Drug to antibody ratio is higher, 8:1 in TDXD versus 3.5:1 in TDM1. Tumor selective cleavable linker, yes, in TDXD and no in TDM1. And a very important thing is evidence of bystander anti-tumor effect is higher in TDXD compared to TDM1. So Destiny Breast 03 was the first randomized phase 3 study, which was an open-label multi-center study. Patients were unresectable of the metastatic HER2 positive breast cancer were taken, and they could have had a clinically stable treated treated brain metastasis. Then they were randomized in 1:1 manner with the primary endpoint of PFS by BICR, with number of key secondary endpoints. So the median age was around 54.3 years in both the groups, and a higher percentage of females. There were good amount of representation across many countries of the world. And around 50% of the patients were hormone receptor positive or negative, and there were participation from patients with brain metastasis as well as visceral metastasis. The median follow-up for the TDXD was 16.2 months and for TDM1, 15.3 months. Very important thing is that there were huge amount of patients who had taken multiple lines of treatment. But this was compared to the initial, the Destiny 01 study, it was still less. The number of lines of treatment was still less. A lot of patients also ended up receiving pertuzumab previously in around 60% of the patients. Now, when we compare the primary endpoint of PFS, it was markedly different and it favored TDXD. So if the median PFS was not reached in the TDXD and it was 6.8 months in the TDM1 group, the 12 months PFS rate was 75.8 in the TDXD with the hazard ratio of 0.28 in the TDXD group. And then in TDM1, it was around 34.1 months. Now, the overall survival data is still too mature, but we do see separation of curves favoring TDXD again, with 12 months overall survival rate of 94.1 months compared to 85.9 months. When we talk about response rates, we see higher response rates. So that means that you also get more depth of response, which has direct bearing on the symptomatic control of the disease, and yes, the quality of life to some extent. So the CR rate and the PR rates were again higher in the TDXD, and we can see that actually the CR rate was doubled in the TDXD group compared to the TDM1 group. When we talk about overall safety summary, we see higher percentage of patients having serious drug-related adverse events in the TDXD group, and we'll just see subsequently what are all these. What was important was the larger number of patients continued TDXD, their treatment for a longer duration of time in the TDXD group compared to TDM1, around 14.3 months in the TDXD and around 6.9 months. So this also had some bearing on the side effects. The most common treatment-related adverse effect associated with treatment discontinuation for TDXD was ILD or pneumonitis, around 8.2%, and for TDMD it was thrombocytopenia, around 2.7%. No, we see a lot of neutropenia with TDXD, and we see a lot of thrombocytopenia with TDM1. However, we also see a lot of GI side effects with TDXD, nausea, vomiting, diarrhea, a lot of fatigue, and yes, a subset of patients might also have alopecia in the TDXD group. In this particular trial, we did not see any grade 4 or grade 5 drug-related ILDs. And yes, a few patients did have a decrease in LV ejection fraction. So this was the first randomized phase 3 trial in the breast cancer, where the TDXD demonstrated highly clinically meaningful and statistically significant improvement in the PFS compared with the TDM1, and encouraging overall survival results, and the safety profile that is comparable between the two arms. However, we do see higher percentage of patients with severe side effects compared to TDM1. So most important adverse event for the TDXD has been drug-induced pneumonitis. In this phase 3 trial, there were no grade 4 or 5 drug-induced pneumonitis as compared to 2.7% grade 5 events that were seen in the Destiny Breast 01 non-randomized phase 2 trial. This was because that this trial had less heavily treated patients population compared to Destiny Breast 01, which had median recall of 5 to 6 prior lines of therapy for the metastatic disease. So overall concerning side effects, but excellent efficacy. Lesser side effects if used in the earlier line of treatment, and more as the more and more efficacy data evolves, and we are more and the safety data evolves, we will be becoming more and more comfortable at using, and this drug will definitely be shifted in the earlier lines of treatment. What was important was in this particular trial, there was a lot of vigilance for the ILDs, usage of steroid, and the prompt action taken to modify your treatment interruption to reduce the ILDs, and that also helped to reduce the severity as well as the incidence of side effects. And this is how in the real world scenario also the practice is going to be. Another part of the trial which was presented in SABCS, this was the subgroup analysis from the randomized phase 3 study, Destiny Breast 03 trial. So very important study in the sense that they took patients with the brain metastasis and the patient with the visceral diseases. So when we compare the results across all the major subgroups, we see irrespective of the hormone receptor expression, irrespective of prior pertuzumab treatment, irrespective of presence or absence of the visceral diseases, prior lines of therapy, and more importantly, presence or absence of brain metastasis, the TDXD arm fared much better compared to the TDM1 arm. And if we compare the overall response rates, we see consistently higher response rates favoring TDXD over TDM1 across all these major subgroups, and also in the patient with brain metastasis. So if we compare the PFS Kaplan-Meier curves of the patient with or without brain metastasis, we again find that the median PFS of a patient with brain metastasis at baseline was 15.0 months in the TDXD group and 3.0 months in the TDM1 group. So marked difference in the median PFS rate. Also, if we compare the intracranial responses per BICR using RECIST 1.1, we see much higher response rates and the higher CR rates as well as PR rates in the patients with the TDXD group. And yes, more patient with progressive disease in the TDM1 arm. Sometimes certain side effects show differences across various ethnicities. And however, in this particular trial, if we compare the incidence of ILD, it was not different in the Asian subgroups versus the non-Asian subgroups. So in the patient with and without brain metastasis, TDXD treatment resulted in the greater efficacy compared to TDM1. With the patient with brain metastasis, the median PFS of 15 months with TDXD versus 3 months with TDM1, with the confirmed overall response rates of 67.4% for TDXD versus 20.5% for the TDM1. And lower rates of progressive disease with the TDXD versus TDM1 for the patient with brain metastasis. So substantial intracranial responses and reduction in CNS disease was seen for the TDXD, and it is demonstrated a manageable and tolerable safety profile, which was not different from across various ethnicities. So most importantly, the drug has powerful activity in brain metastasis and actually from across all the sites of metastasis. So we now have more clarity in the sequencing in the patient, especially in the patient with brain metastasis, which is actually sometimes could be a big nuisance in the patients with HER2 positive disease. No difference in side effects of the FEKC for TDM1 based on the ethnicity, prior therapy, and hormonal receptor status, and the sites of metastasis. Another very important study, the updated results of the tucatinib versus placebo added to the trastuzumab and the capecitabine for patients with pre-treated HER2 positive metastatic breast cancer with or without brain metastasis, the HER2 CLIMB study. So tucatinib is a highly selective HER2 directed TKIs approved in the multiple regions in the combination with trastuzumab and capecitabine for adult patient with metastatic HER2 positive disease. The HER2 CLIMB trial evaluated tucatinib versus placebo, both in combination with trastuzumab and capecitabine for HER2 positive metastatic breast cancer after progression on trastuzumab, pertuzumab, and TDM1 in any setting. So this was 2:1 randomized study where 3 drugs were actually compared to the 2 drugs. So if we compare the PFS by the investigator assessment, we see a hazard ratio of 0.57 favoring the 3-drug combination compared to the 2-drug combination, with the median PFS of 7.6 months compared to 4.9 months in the doublet. So PFS benefit with tucatinib was maintained with longer follow-up. So we see a difference at 6 months, at 1 year, and we see a maintained differences in these two groups. And when we compare overall survival, it was 24.7 months in the 3-drug combination and 19.2 months in the group without tucatinib. So overall survival benefit with tucatinib was maintained with longer follow-up, with a 5.5 months improvement in the median overall survival in the tucatinib arm compared to the placebo arm. And the differences of at 1 year was around 75% to 65%, 2 years it was 51% compared to 40%. Now, when we compare the overall survival in the pre-specified groups, we see that the 3-drug combination, which included tucatinib, is favored over the placebo arm in across all the major subgroups. So overall survival benefit with tucatinib was generally consistent across patient subgroup, irrespective of age, ethnicity, hormone receptor status, presence or absence of the brain metastasis, performance status, and the region. And also we see that irrespective of the presence or absence of visceral metastasis, the 3-drug combination favors better. The rate of treatment discontinuation remained low, similar to the primary analysis, and the tucatinib regimen continued to be safe and well tolerated with a longer follow-up. So we do see higher grade 3 side effects in this group compared to the trastuzumab capecitabine only group. But we do know that what are the usual side effects of these group of drugs. It is usually diarrhea, palmar-plantar erythrodysesthesia syndrome, some amount of GI side effects, fatigue, alteration in liver functions. So overall survival benefit with tucatinib was maintained with the additional 15.6 months of follow-up, and it was maintained across all pre-specified group. Irrespective of presence or absence of the visceral metastasis, the difference in the clinical, the improvement in overall survival was clinically meaningful. And yes, the progression-free PFS analysis per investigator assessment was consistent with the primary analysis. So tucatinib in combination with trastuzumab and capecitabine was well tolerated with a low rate of discontinuation due to adverse events. And discontinuation was infrequent in both the arms. Safety profile was consistent with the primary analysis. So the important thing is that we are comparing 3 drugs with two drugs. So the trial does show that the tucatinib has reasonable activity in HER2 positive disease, especially in the patient with brain metastasis. However, we don't know how will it fare compared to the other HER2 blockers, especially dual blockade. The drug has manageable safety profile, so it will be a useful adjunct in the real world scenario. Thank you.